Hello everyone, I am Vikas and I am going to present the seminar about acute myeloid leukemia and chronic myeloid leukemia, bone marrow and peripheral smear findings. Pathology of myeloid leukemia. Learning objectives are acute myeloid leukemia to analyze the mechanisms of bone marrow failure and understand the pathognomonic diagnostic morphology of immature myeloblasts and other rods. In the chronic myeloid leukemia, the learning objectives are to understand the neoplastic proliferation of mature granulocytes, pathogenetic significance of T922, and peripheral blood smear presentation. Hematopoiesis overview. Hematopoiesis is the formation of the erythrocytes, the myeloid progenitors. It arises from pluripotent hematopoietic stem cells in the bone marrow. Regulated differentiation. Healthy hematopoiesis preserves balanced development into mature functional leukocytes. Neoplastic deviations. Disruption of these checkpoints initiates myeloid clonal expansion, defining leukemic pathways. Introduction to AML. Definition: acute myeloid leukemia or AML is malignant clonal neoplasm characterized by a blockage in differentiation and the progressive accumulation of immature myeloblasts. Pathogenesis of AML. Genetic mutations disrupt transcription factors required for normal myeloid maturation, causing the marrow to become choked with proliferative yet non-functional cells. Robbins and WHO criteria. Blast threshold. It is diagnosed when myoblasts account for total bone marrow or peripheral blood cells, that is 20%. Exception: certain genetic translocations like T821 or IN16 qualify as AML regardless of the blast percentage, that is 20%. Modern classification shifted from legacy FAB criteria towards genotypic and lineage specific categories. Peripheral smear findings in AML. Myeloblasts, large cells containing a high nuclear to cytoplasmic ratio with round to oval nuclei. Nuclear chromatin is delicate, finely dispersed, open textured chromatin resembling a tissue paper. It is more finer when compared to the lymphoblasts. Nucleoli characteristically features 2 to 4 prominent nucleoli per blast cell. Here we can see that there is a large cell with the round to oval nucleus with fine chromatin and 2 to 4 nuclei and scanty cytoplasm with fine granules. Crystalline cytoplasmic inclusion as a result of abnormal fusion of azurophilic granules. They are the rods we can see here, also here and here. Pathognomonic rods. Rods are the characteristic feature of AML. Rods morphology. Rods are elongated, needle-like, red to pink in color, azurophilic structures in myeloblast cytoplasm, formed by crystallization of lysosomal enzymes, chiefly myeloperoxidase. Their presence conclusively confirms myeloid differentiation, excluding lymphoblastic origins. Here we can see the rods. They are more in number compared to the previous slides. AML bone marrow findings. Hypercellularity. There is extreme cellular crowding reaching up to 100% of the available spaces. Monotonous sheet. The packed with sheets of morphologically uniform undifferentiated blasts. Effaced architecture. The normal spatial orientation and cellular heterogeneity are lost. Suppression of normal lines. There is erythroid suppression and megakaryocyte loss. Erythroid suppression. Erythroblasts are squeezed out by expanding blasts, resulting in clinically severe normocytic normochromic anemia. We can see anemia, that is normocytic normochromic, in the AML. Megakaryocytes loss. Megakaryocytes are depleted, causing profound peripheral thrombocytopenia with subsequent risk of critical hemorrhage. Cytochemical stains. Myeloperoxidase. They are classically positive, demonstrating granular cytoplasmic staining in myeloblasts. Sudan black B. Stains intracellular lipids. Positive staining confirms a myeloid lineage. Non-specific esterase. Primarily positive in monocytic leukemia, that is AML M4 and M5, helping distinguish blast lineage. These are the stains which differentiates myeloid leukemia with the lymphoid leukemia. In the lymphoid leukemia, these stains does not give any color. APL pathological variant. Phagot cells. The features of hypergranular promyelocytes containing numerous clustered air rods resembling a bundle of twigs, that is called phagots. Pathogenetic target. They are driven by T15 and 17, translocating the PML-RARA gene, causing susceptibility to therapeutic differentiation therapy using ATRA. Blast threshold metric. As I already told, 20% myeloblast is the criteria. If there is more than 20% myeloblasts in the peripheral smear, it confirms that it is the acute myeloid leukemia. Absolute diagnostic threshold. The cardinal cytomorphological benchmark required by the WHO or Robbins guidelines to diagnose AML. Any myeloid presentation with lower blast levels, excluding specific clonal cytogenetics, is classified as myelodysplastic syndrome. Chronic myeloid leukemia. A comprehensive examination of peripheral blood smear, left shift, and hypercellular bone marrow pathophysiology. Introduction to CML. Neoplastic definition. Chronic myeloid leukemia is a myeloproliferative neoplasm characterized by overproduction of granulocytes that retain their maturation capacity. Proliferative drive. Driven by neoplastic stem cell proliferation, allowing massive myelopoietic output with progressive maturation steps intact. BCR-ABL1 translocation, Philadelphia chromosome formed by reciprocal translocation T922 Q34 Q11. Fusion oncoprotein generates the chimeric BCR-ABL1 protein with constitutive tyrosine kinase activity. Mitogenic signaling drives autonomous stem cell growth pathways bypassing standard regulatory signals. CML smear and left shift. Severe leukocytosis can be seen. The WBC counts typically exceed more than 1 lakh per microliter. Spectrum of maturation. Classic left shift showing cells at all stages. That is, myelocytes are seen, metamyelocytes are seen, bands are seen, and neutrophils are also seen. The myelocyte bulge. Striking peak in myelocytes, outnumbering the other immediate precursors. Here in the peripheral smear, we can see immature granulocytes, basophilia and eosinophilia. These are the myeloid precursor cells, that is promyelocyte, metamyelocytes and the band forms. We can also see basophils and eosinophils as a result of basophilia and eosinophilia. These are the normal neutrophils. These are the band forms which has a horseshoe shaped nucleus. These are the promyelocyte and the metamyelocytes. Basophils and eosinophils. Diagnostic clue. Absolute basophilia is a hallmark feature of CML. Basophilia is not seen in other type of leukemias. Finding high numbers of mature basophils is strongly suspicious of this disease. Eosinophil shift. Parallel increase in mature eosinophils and their precursor is frequently observed, representing global myelopoietic drive. Acceleration sign. Progressive uncontrolled rise in basophils, that is more than 20%, often signals transition into accelerated phase. Normally, basophils are seen in 0 to 1% in the peripheral smear. Dwarf megakaryocytes. Atypical morphology. Megakaryocytes are characteristically smaller than normal and shows hypolobated nuclei. Hence, they are called as dwarf micromegakaryocytes. Platelet association drives marked thrombocytosis, frequently exceeding 450 K per microliter in early stage disease, presenting with functional platelet aberrations. CML bone marrow findings are maximal cellularity, Marrow is essentially 100% cellular with complete disappearance of standard fat spaces. Skewed ME ratio, that is myeloid to erythroid ratio. The myeloid to erythroid ratio is shifted from the normal, that is 3:1, up to 20:1 or 50:1. That is myeloid are increased in number to 6 to 10 times. Reticulin fibrosis. Scattered reticulin deposition is common, reflecting high cytokine turnover. Sea blue histiocytes. Pathophysiology. Massive myeloid turnover leads to phagocytosis of cell membrane lipids by bone marrow macrophages. Microscopic appearance. These macrophages become packed with blue-green lipid debris, morphologically resembling Gaucher cells under standard stains. So they are called sea blue histiocytes. Triphasic course of CML, that is chronic phase, accelerated phase, and the blast crisis. Chronic phase, stable myeloproliferation with less than 10% blasts, highly responsive to therapy. The accelerated phase, elevated blasts, that is 10 to 19%, and with absolute basophilia, that is more than 20% of basophils, refractory thrombocytosis. Blast crisis, transformation to acute leukemia with blasts exceeding 20% in blood or marrow. Blast crisis lineage map, that is myeloblastic crisis up to 70% and lymphoblastic crisis up to 30%. Note that CML stems from a pluripotent stem cells, allowing blast crisis to affect both myeloid and lymphoid lineage. Diagnostic comparisons. Pathological features, it is primary defect. In acute myeloid leukemia, it is differentiation block at precursor stage, whereas primary defect in chronic myeloid leukemia is overproduction with preserved maturation. Classically, in marrow and blood blasts, classically in acute myeloid leukemia there is more than 20% of the blast cells, whereas in chronic myeloid leukemia there is less than 10% in chronic phase. Usually it is considered less than 20%. Key smear findings. In acute myeloid leukemia, immature myeloblasts are seen with rods, that is pinkish rod-shaped structures. In chronic myeloid leukemia, the key smear findings are left-shifted granulocytes with basophilia and eosinophilia. Megakaryocytes in the acute myeloid leukemia are suppressed or depleted, whereas in chronic myeloid leukemia the megakaryocytes are increased in number with atypical dwarf morphology. The myeloid blast comparison. AML blast count average is 85%, CML blast count is 5%, CML blast count in chronic phase is 5%, whereas CML blast count in accelerated phase is 15%, CML blast count in blast crisis is 35%. Yes, and thank you.